Top Bed Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Bed Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
This piece is presented by Dr. Ryan Hansen, anesthesiologist in Boston, Massachusetts, affiliated with Brigham and Women's Hospital. He received his medical degree from Penn State College of Medicine. Have a listen.
Hi, I'm Ryan. Just to give you a quick background on where I train and sort of inform perspective on my take on ERAS and how to manage analgesia in this setting. I trained mostly Tulane in New Orleans and then finished up with the military in San Antonio, deployed from there, and then worked some in the pain clinic as well as helped manage some of the chronic pain as well as the ICU and the patients coming back from the Gulf War in Afghanistan and in Iraq. So it's the principles that I found there inform what we're going to discuss today, and I think Dr. Senegor's comment about just keeping things simple is actually one of the wisest things that you can discuss when it comes to ERAS. So again, to focus on orthopedics, how big is ortho and what kind of issue are we dealing with there? There are over 1 million total joint replacements a year and climbing. It's in most of our hospitals, I think, one of the highest volume surgical lines. And then obviously hip fractures, as we discussed earlier in the conference as well, is a growing problem and something that we have to deal with in terms of comorbidities, how we manage these frail patients, and how we get them out of it relatively unscathed. So there's especially, I would say, not just the elderly patients, but the frail patients are the ones that we have to watch out for, especially when we're dealing with and planning our analgesics. All right, so what are the principal problems in dealing with analgesia in the orthopedic population? Well, opioid dependence, as we're all aware, is obviously in the news. And one of the things that we've looked at is how long those patients have to be on opioids in order to become dependent on them. And it can be occurring in as little as 5 days. So the more that we can do on the front end to reduce their dependence on postoperative opioids, the better they're going to be long-term and reduce their risk of postoperative dependence. Postoperative cognitive dysfunction, again, has been a big theme at this conference and something that we're all looking at and trying to improve in that frail population. So how do we do things so that we address their analgesic needs, we get them through the perioperative period safely, but we minimize our impact on their cognitive dysfunction postoperatively? Post-op respiratory depression is an area that I get a lot of encouragement from, actually. Dr. Ramsey's work here with our BREATHE team, I think nationally, we've gotten away from the primary concern being respiratory depression and sedation and really got into a little bit more global view of how we manage analgesia. So that's an area, I think, where we've made a lot of strides in our specialty, although certainly there are some areas for improvement there. Lack of appropriate analgesia and hyperalgesia long-term is again, continues to be a concern. And then patient experience and cost, right? So we can get around a lot of the issues with potentially lowering the opioid doses through education, which we've talked about as well. And experience, HCAHPS scores, cost are going to become more and more important for us as we get into more of a bundled care type of environment moving forward. So these are certainly considerations. So my partners, we all in this room, we're obviously interested in enhanced recovery and in perioperative medicine. How do you manage change, right? So, one of the big barriers is how do you get people to get out of their old habits and into things that are actually evidence-based and things that we know to be the standard of care moving forward. And so I think that really we're almost post-ERAS. Certainly those of us in the room are. And it really is just best practices at this point, right? It doesn't have a label. It doesn't have to be a protocol. It's just looking at each patient and what is the right thing for them and then standardizing things where it's appropriate. I think to just summarize my view of ERAS, it's minimizing our disruption of their normal physiology, returning to their baseline as soon as possible. And then this dialogue, education, and execution is really not so much, it doesn't end at execution. We were just talking in the hallway before this lecture, and it really is a cycle, right? You have to get together with your colleagues, surgical, anesthesia, nursing, education, and agree on what are the best practices for your hospital and your setting for your patients. You have to educate your staff and your patients, and then you have to execute. And then the key is to not stop there. You really have to then loop back to the first phase, and it's an ongoing cycle, and that requires those of us in this room. It also, in our experience, requires a really functional, a nurse coordinator, a program coordinator that is kind of the glue and sort of the hub in that wheel that turns around. So just a few sites to look at for multimodal analgesia. We've talked, a great discussion of methadone. We talked about NSAIDs as well. And so I just see these as opportunities, right? So you can look centrally, descending modulation. You can look at transmission, both in the spinal cord, the peripheral nerves, and the peripheral nociceptors. As we get through, just to kind of touch on these, you guys are all familiar with general versus neuraxial debate, and I'll touch on that in a minute. Regional analgesia, I think, is one of the cornerstones. Certainly in orthopedics it is, and I would say it's one of the elements. It doesn't have to be any given block, but pick a block that you can give your patient. I would also pick one of the list, at least, if not several. PO analgesics are key. And we've gotten to a point now where we have so many options. Again, you can look at, depending on the population, whether in colorectal versus orthopedics is a little bit different consideration. But in our patients, we're giving celecoxib, a gabapentinoid, and then PO acetaminophen ideally. Sometimes we're giving an IV, but I think we're going to really move towards the PO. And it's cheap, right? It works. It's effective, especially in conjunction with the NSAIDs and a block of some sort. And, some of our surgeons are still combining that with an opioid, but I think that it's really not necessary in most settings. And then an IV analgesic, right? So methadone is one of my favorites. I was excited to see Dr. Murphy's lecture on that. I was probably my team and people that work with me know that for a long time I probably used more methadone in our hospital than anyone else. I still think it's a great drug. You have to be careful with it. You have to know your patient, et cetera. But I really, for a lot of reasons that Dr. Murphy went through, I think it's a fantastic drug. And then ketamine has become something that we used tremendously, and actually we use that as one of our primary rescue drugs now too. So not only do we use it in the OR, either as a bolus dose or an infusion. Some of our team are here today, actually. They used it and get them set up. That infusion now can run through into PACU and actually out onto the floor. And so that's been one of our primary strategies to reduce opioid use in the whole perioperative period. We use it in the ICUs now. And then, like I said, even on the floor, we found it to be a safe alternative to using PCAs. Many of our more progressive teams and surgeons have gotten away from using PCAs altogether because they can just continue that. Ketamine, our colorectal service, Dr. Peters, who spoke yesterday, is doing that and really helped pioneer that along with our other staff and med staff. And then obviously dexmedetomidine is kind of a very specific thing, and we can maybe get into that with some of the discussion later, but that's a great drug in certain circumstances. So again, just to kind of run through some of the basic principles that we've gone through and been successful for us. Prehab especially, so some of our total joint population will actually go through a physical rehab process prior to coming to us. Patient education is fundamental, and I'll touch on that in a little bit, but if you don't do that piece of it, then ERAS really is not going to be nearly as effective for you. Really managing their expectations, managing families' expectations, and your staff that's going to be carrying those patients and really kind of shepherding them through the process of their perioperative period. And then it doesn't really matter how you do it. In our experience, a clear liquid up to 2 hours before surgery in most patients is the most effective way to get them through that period. You can do Clear Fast or Gatorade or coffee. I think which liquid you give them is less important than just keeping them hydrated, especially when you go back to like the hip fracture population. And that's been one of the interventions that we've done recently in our process of going towards a center of excellence for hip fractures, is just to keep those patients, they're 85, they're 90, they're 94, and you make them NPO the night before, and now they've gone until 4 p.m. the next day, and they're dehydrated, and you can imagine what's going to happen with induction of general or spinal anesthetic. So that's been a key element that we've added recently. So this is one of the things I hope to talk about on the panel, is general anesthetic substandard? Is it not the standard of care to give a general anesthetic to someone that has a hip fracture? And I think in my practice, we actually do more general anesthetics than we do spinals. My personal opinion, and in my experience, if you do the right anesthetic for that patient, it doesn't really matter whether you're doing a spinal versus the general, as long as you're not just, you're not hammering them with a bunch of narcotics, opioids, et cetera. So we've been able to do it in a way that's safe. Our surgeons prefer it that way. And so in this setting, we found it to be an effective way to handle anesthetic. But I think that's an interesting point. I don't think that debate is settled yet. It's probably as controversial as the crystal versus colloid discussion as well. And then, again, just regional versus spinal. Again, even if you do the spinal, oftentimes you'll have to give them sedation. So that sort of hedges or buffers that discussion as well. Just to run through, we do a ton of adductor canal blocks here. We find that they are, there's certainly support in literature for this as well. They're equal analgesic to the femoral nerve block in some settings. I still find the femoral nerve block to be more effective in patients that are opioid tolerant, that have, that I expect to have a higher analgesic requirement in the perioperative period. Or if I'm just not worried about sparing the quad in the setting of an amputation, that sort of thing, then I'll just go with the femoral nerve block. But for, we do a ton of these every week, and I find that in combination with the periarticular injection, which many of our surgeons still do, it's very effective at reducing opioids. And so again, you just sort of look at the building blocks of an effective analgesic program. You have, prehab and education. You have a PO analgesic. And then you have some form of regional anesthesia. In this case, both the surgeon and our service are doing one. And then you have minimum opioid sparing and rehab and early ambulation afterwards. And we found that to be an excellent regimen for our patients. Fasciliaka, I think, again, we do these for some surgeons and some we don't, based on preference and our dialogue there. We found in a study a couple years ago from regional anesthesia and pain medicine that it's actually more effective to use ultrasound versus the traditional anatomic sort of two-pop technique. I think we've all experienced that in our regional anesthesia practice, that you see the anatomy so much easier, and so your success rate is going to be higher if you use ultrasound. And then whether or not using fasciliaka for hip fractures, I think is another interesting point of debate. We're using it in some settings. Hip fracture is another interesting question, whether or not and when patients should be getting a fasciliaka block. And in our practice, it's been a challenge to get down to the ED, so we're still working on that dialogue with the ED physicians in terms of when and where that block should go in. But I do think that that's a potential area for improvement for our practice. So without kind of delaying the point, I think that our experience, we actually started here with our former chair of orthopedics with ortho for ERAS. We found a lot of the same success that you'll find in the literature, and then colorectal, and Dr. Peters really kind of picked up that flag and has run with it, and we've had great success in the colorectal program. Other services now, gyne, urology, really, we have a mandate now from the hospital and from our medical staff officers to really roll this out across the board, not because it's a protocol per se, but because it really is just best practices now. So the hospital has seen the benefits in terms of better analgesia, the patients are more satisfied, they leave home. Again, our results really mirror what you find in the literature. So what we're telling them now is that the key to that, really, like I mentioned before, is having that program coordinator and having that sort of hub at the center of your wheel that spins, your dialogue, patient education, and then picking the elements that we talked about: education, PO analgesic, some form of regional, and then keeping the dialogue going.
Top Bed Talk.
Nick Majerison here. Have you got yourself onto ebpom.org yet? If not, you might not be aware, EBPOM Chicago tickets are free for a limited period only. Go now to ebpom.org. Evidence-based perioperative medicine. ebpom.org.